Hello, and welcome to City Health's 2021 Policy Assessment of America's 40 Largest Cities. I'm Katrina Forrest, one of the co-executive directors of City Health, along with my counterpart, Catherine Patterson, whom you'll hear from in just a moment. Today, we are so excited to share the results of our annual medals and to celebrate the amazing achievements that city leaders have earned over the course of our inaugural policy package. In just a few minutes, we'll welcome several public health leaders from City Health's all-star cities to talk more about their successes and what it takes to adopt the health policies that can lead your city to improved health. But first, for those of you who are new to City Health, welcome. We are an initiative of the Beaumont Foundation and Kaiser Permanente, and we partner with the visionary city leaders to adopt a package of tried and tested policy solutions that ensure people in our largest cities have access to healthy choices and the opportunity to live healthy, full lives. This is the 5th year that we have evaluated America's 40 largest cities on our package of 9 policy solutions. Our policy package focuses exclusively on upstream prevention-oriented policies that are designed to help people in cities have access to a safe place to live, a healthy body and mind, and a thriving environment. Our policies also center equity. At our core, we believe who you are and where you live should not determine your opportunity to live your healthiest and fullest life. And that policy is an important tool to help address critical health disparities. 2021 marks the final year that we will assess cities on our current policy package. Starting next year, we'll be working with cities on a new package of policy solutions. We'll have much more to say about our new policies soon, but today we are so excited to share the incredible progress our cities have made this year and also celebrate the overall successes that we've seen over the course of our inaugural policy package. As we close in on nearly 2 years of the COVID-19 pandemic, which is just mind-boggling, I think we can all agree that things have been tough for everyone. But I think it's important to acknowledge that for city and public health leaders, the past 20 months have been extremely difficult and a true test of your leadership. And yet, despite the challenges, city and public health leaders continue to prove their resilience. Across the country, these leaders are redefining what health means for their cities, and they are taking action to create better health outcomes for everyone. The results are in. This year, we are proud to announce our greatest achievement in policy success to date. 92.5% of America's largest cities have earned an overall City Health Medal in 2021. 37 out of the 40 largest cities have earned medals in at least 4 individual policies, qualifying them for an overall gold, silver, or bronze medal. That means that more than 44 million people who call those cities home will benefit from these health policies that can improve their lives for decades to come. Looking at the overall medal results, 10 cities have earned an overall gold, 11 cities have earned an overall silver, and 16 cities have earned an overall bronze. Congratulations to all of the city officials, public health leaders, and advocates who have worked tirelessly to improve the health of your residents through policy. These cities have truly set the bar when it comes to adopting upstream health-focused policies. While everyone's success here is laudable, we do want to recognize the achievements of one city in particular. We are proud to welcome Albuquerque to the exemplary group of gold medal cities. Albuquerque's gold medal was awarded for earning individual gold medals in complete streets, earned sick leave, high quality accessible pre-K, smoke-free indoor air, and tobacco 21. Additionally, the city earned a silver medal in healthy food procurement. Albuquerque first earned an overall bronze medal in 2018 and turned that into an overall silver in 2020, demonstrating that steady improvements can lead to considerable long-term progress. From all of us at City Health, congratulations to the city on this accomplishment. We celebrate your commitment to health and look forward to working with you on our new policy package starting next year. And with that, I would like to now turn it over to my colleague, Catherine Patterson, for a look back at City Health's first chapter.
Katrina, thank you so much. Hello, everyone. It's great to be here with you today to talk about this milestone for cities and to take a look back at our inaugural policy package. I'd like to start with a chart that I think illustrates not only the journey of the initiative itself, but is also indicative of how cities are starting to rethink and redefine health. When CityHealth first released our first assessment in 2017, less than half of cities, about 48%, qualified to earn an overall medal. You know, to be honest with you, we were not sure how cities were going to receive this assessment. Would cities even care about this brand new initiative that was rating their health policies? Would earning medals even matter to them? We got this answer pretty early on when we got a phone call from former Mayor Ron Emanuel's office in Chicago saying, "Oh, we are so excited. We're so pumped about our gold medal. When is it going to arrive? We want to take a picture with it." We had not planned on actually creating medals. We thought these would live on the internet. They would be icons. But you better believe that we made a medal, sent it to Mayor Emanuel's office, and he took that picture, which we were super excited about. What we learned in this whole process is that cities love to compete. And honestly, when they are doing something incredibly innovative, they want to share it with the world. As you can see on this chart, every year since that initial assessment, more and more cities have joined this movement for health. City leaders have told us that our policy package makes the healthy choice the easy choice. You know, that's really our goal here at CityHealth. We love to hear how city leaders are redefining health, that health is so much more than just healthcare, and that by taking upstream prevention-oriented actions, we can even prevent health problems before they even begin. You know, this chart provides more evidence that cities are joining the movement for health, not only by adopting policies at a greater rate, they are also striving to pass higher quality policies. The yellow line on this chart represents the gold medals we've awarded for individual policies. In 2017, that number of gold medals comprised about 46% of the total number of medals we awarded. Today, I am proud to report that gold medals represent over 60% of the medals we've awarded. More cities are passing stronger policies, increasing the benefits to their residents. It's a virtuous cycle that we hope continues to echo throughout the country. You know, those last two slides have shown graphs of the amazing growth that we have seen overall and in individual medals as well as overall policy medals. But they really don't tell you the story of what it's taken for cities to adopt these medals for the health outcomes or the health outcomes that their residents have experienced. Along with this year's report, we are releasing a retrospective on our first chapter, chronicling the origins of CityHealth, how we've developed our first policy package, and most importantly, how cities have responded. We chronicle the journeys of four cities that four cities have taken: Atlanta with smoke-free indoor air, Denver with their Tobacco 21 policy, San Antonio with their high-quality accessible pre-K program, and Seattle with healthy food procurement. Today, we're welcoming leaders from three of those cities, Denver, San Antonio, and Seattle, to share their stories in our upcoming panel. You can find the complete results, including our retrospective and our methodology, at cityhealth.org. You know, I'm noticing some questions in the chat, which is great. We would like to open it up now for additional questions. If you have a question, go ahead and enter it into the chat box. You know, it's a really interesting question, how many cities have improved two or more criteria over the course of this effort. That particular question, I think, is fascinating because we have actually seen many cities improve year over year in terms of the number of medals and the number of policies that they've actually passed. So we have almost doubled since 2017 the number of cities that have actually passed and have an overall policy, an overall medal, which is amazing to me, you know, going from 48% to 92%, which is pretty fantastic. Katrina, I see another question in the chat box. Did bronze medals go down because policy strength was increased or swapped out with gold? If so, that is an important finding. It is not just the number of policies rapidly replicated, but the strength of the policies too. Do you want to talk a little bit about that?
Sure, I'm happy to. And the answer is yes. We have seen the number of bronze medals go down because cities have been able to advance either to gold or silver, which is incredible. Catherine spoke to this in her remarks a few moments ago, but we really are seeing that not only are cities pursuing the policies in our package, but they're also wanting to go farther, faster, and make sure that their policies are stronger along the way, which is incredibly exciting.
Thank you so much, Katrina. Those are great questions. I would highly encourage you to put more questions in the chat box, and we will make sure to address them. You know, it is now my pleasure to introduce our moderator for today's panel, Aisha Pamaku. Aisha is the Policy Fund Initiative Officer with the San Francisco Foundation and is the founder of Movement Praxis, an equity-centered organization that provides solutions for complex systems through law and policy, capacity building, and philanthropic strategy. Aisha, I turn it over to you.
Thank you so much, Catherine and Katrina, and congratulations again to the City Health team and to our amazing leaders in local government. We really applaud and admire you, especially at this time. So I'm gonna go ahead and invite my panelists to turn on their videos and to join me. I'm really excited to be here in amazing company, and it's really a pleasure to moderate this conversation. Again, my name is Aisha Pamaku, and just as we get started, I'd like to frame our panel discussion by saying that something that really unites our panel and really the entire team here is that we believe in the power of local governments to help people live their healthiest lives. And we also know that policy is one of the most powerful tools that we can use. And this is because that everyone on this call right now understands the urgency of the moment, right? We all know the threat of COVID is not over and communities are still hurting from its impact. We all know that racism looms large as a public health crisis. And in all of this, our local governments, as we are seeing in this presentation, are absolutely on the vanguard of the innovative solutions that are promoting justice and equity. So the folks who will be speaking today really exemplify this commitment to health equity. I'm going to give very brief introductions that I assure you will not do them justice, but I want to make sure we have a lot of time for our rich discussion. So with that, today we are joined by Claude A. Jacob, Metro Health Director for the City of San Antonio. He came to this role with a wealth of public health experience, including serving as Chief Public Health Officer for the City of Cambridge in Massachusetts. We have Tristan Sanders, the Director of Community and Behavioral Health for the Denver Department of Public Health and Environment. His background includes community benefit work at Kaiser Permanente, Colorado. And of course, we have Patty Hayes, the former Director of Public Health at Seattle and King County, who steered the department out of financial challenges and championed new resources and programs for the community. I should also add that all of these folks were instrumental in the massive mobilization and community engagement needed for emergency COVID response. So no matter how you look at it, we are really amongst our public health heroes here. And just on a more personal note, I want to add that among our panelists, we have a 5-time marathoner, we have a nationally competitive amateur golfer, and we have a budding quantum cosmologist. And I just say that personal note with pride because the public health workforce never fails to impress me with some of the most passionate and fascinating people that you will meet. So for our audience, again, you're invited to engage in the conversation using the chat, including any questions you may have for the panelists. And towards the end of our conversation, we'll do our best to pull a couple questions from the chat. So let's go ahead and dig in. I'll start with a question, and anyone feel free to jump in. But each of you plays such a powerful role as a convener, a connector when it comes to policy adoption and implementation. And let me make an understatement and say that it's really hard work aligning across your mayor, your council, your city agencies. So can you talk about what strategies have you found to be effective when it comes to bringing people together for policy efforts? And what are some things that our local leaders should be trying to do and trying to avoid?
Well, Aisha, I'll jump in first. Thank you so much for the opportunity to be here today. I'm just greatly honored to be with you in City Health, very proud. and my distinguished colleagues. It's just a joy to be here, so thank you so much. You know, for us in King County and in the city of Seattle, I think a couple of things I would start out as I reflect is timing is everything. And part of the things at the local health level is you have to be active at the state level as well. And the leadership that we work, because some of these efforts and some of the areas that City Health assesses in Washington State actually required legislative action at the state level. And so because we in King County were able to be visible within those, as we saw the success and as we saw the energy, the partnerships expanded and the energy around additional evaluation, additional policies came to light. And we built on the idea of mutual benefit, which I think is really important when you deal with organizations. You need to start with what they think are important pieces to move forward and to work with them.
I'd like to jump in as well and just echo Patty's sentiments. It's an honor to be on this panel and be with all of the attendees. I see a lot of names from past and a lot of friends, so it's great to see everyone. And I think I could echo Patty's sentiments on the answer as well. But timing is everything, absolutely. Measurement is really important, and being able to approach everything with data and evidence. And then the one I'll really talk about is actually considering all perspectives. You know, every time we approached a policy, we considered every side of the issue. And so often when we would go before the mayor and before city council, we would get asked about, you know, have you considered all sides? And we really did our homework. You know, we made sure that we reached out to all corners of every issue that we considered, and that we, you know, whether we agreed or not, we made sure that we brought forth what people were saying and how whatever policy we were putting forth would impact folks. And, you know, I think that just shows that authentically listening to the people that you're trying to work with and trying to work for really goes a long way in policy development. And that would be, you know, along with timing and measurement, I think the third most important thing that I would put in there.
Greetings. Just want to add to this conversation. Again, thank you, City Health team, for this wonderful invitation to share. And I bid you greetings from sunny San Antonio. So yes, I spent 14 years as a health officer for the city of Cambridge, Massachusetts. Proud of the work there, and just want to at least pivot and talk about the lens. I've just been here a few months, but I did want to add to the comments already by Patty and Tristan. So in addition to their comments already shared, I would add just being very intentional in our collaborations and our partnerships on the ground. We've learned this and the importance of that through this COVID storm. We've found to be an effective strategy on the ground to support existing coalitions, to mobilize new coalitions and partnerships where needed. We realize that the COVID storm has forced us to make sure that we make other friends on the playground to get through this unprecedented experience. So, and you can't make that up. You have to be genuine in how that happens. So I tend to describe it on the ground talking about BMI, and I don't mean body mass indices, but it's about being more intentional in our partnerships and our collaboration. So that's one strategy we found, and we are still finding to be effective on the ground. It's also important to anchor not only to the science of our work and to make data-informed decisions, but it's really about aligning our efforts with our partners that include our elected officials. So all that, again, consistent with the other comments, have been some of our most successful strategies. Again, and I can share that from that vantage point, being here, new here in San Antonio, but also acknowledging that that was the lens, at least as a health officer in the city of Cambridge.
Thank you all. Really appreciate those insights. You know, and digging into the topic of health equity, we've really seen the way that racism specifically is at the heart of why people's health is unfairly tied to who we are and where we live. And we've seen our local public health leaders, you all included, across America responding with robust health equity agendas and policies that address racism and address other forms of discrimination that hurt our health. Would love for you to talk about how health equity fits into your approach to public health, and why you think it's important for city leaders to, what you think it's important for city leaders to understand when it comes to health equity centered policies.
I'll chime in and defer to my colleagues. So clearly this COVID storm, while it's been a long 20 months around the globe, the experiences, the conditions that communities have had go back much longer than that. And so just knowing on the ground, we have an Office of Health Equity anchored at our department here at Metro Health. It's been in play for 4 years. We have an equity action plan, and we're working with other partners, especially the Office of Equity here in the city of San Antonio. So part of the experience over the last 20 months is to figure out what are the challenges that we're seeing on the ground. So we noticed early on the unevenness of how the COVID experience was impacting pockets of the San Antonio community. So using heat maps, using different ways that we could look at the burden of new cases and existing cases in community. So we tried to deploy resources to support that, whether it was COVID testing, the pop-up clinics, or making sure that we work particularly with partners on the ground in those particular neighborhoods. And so it allowed us to overlay and become very intentional in how we address this COVID storm. But the point being, these conditions across race, ethnicity, socioeconomic status didn't just start in the last year and a half. And we've had to become even more intentional with our partners on the ground. So just acknowledging that what COVID has done is exacerbate what we've seen on the ground. And I do want to acknowledge that our city council last summer, akin to over 200 communities across the United States, did issue a formal resolution declaring racism as a public health crisis. And so this dovetails with our equity action plan, but also it's served as an accelerant of sorts to mobilize other resources, anchoring to data so that we can address these disparities on the ground.
Similar to what Claude just said, King County has a long history of working to dismantle structural racism. And we have been using that data and really looking at how to build an equity plan, and particularly in COVID, lead with equity in everything. And part of our strategy that we used here that has, in answer to the question that was in the chat box about strategies for community, is to test and really move the planning and decision-making to the community. I think we're all learning what it means to be community-led, community-driven. I don't even like the word engagement anymore. It's not about public health, bringing something forward and then engaging the community and then going back into a black hole and somehow making it so. That just, it never, from my perspective, never worked. And we took the opportunity before the pandemic, and I'm so grateful because we had this relationship built already where we were paying local community-based organizations to lead policy efforts with the community. And we expanded that by hiring community members from the most critical areas where we knew that there was high disparities happening, and building the power within those community-based organizations. And I love to stand with those community organizations as they're talking about the health and their vision for their own community. That's been a real joy in my career. And I think it's a huge learning of how we have to ramp that up with what we've experienced in COVID, because we know when we measure that disparities have gotten worse over time, they have not improved. So we need to find these innovative ways to really turn that around.
Yeah, I'll chime in and just say that, I think some of the evolution in the conversation around equity that I've seen and that I've been most excited about is that, probably 5 or so years ago when I first came to the city, there was a conversation about, what is our equity strategy? And it was sort of singularly focused on the equity strategy. And it's sort of morphed over the years, I think, in a really good way to say that we actually consider equity in all that we do. And it kind of mirrored the sort of help in all policies strategy in that there's equity in all policies. And there's a number of ways that that materialized that I think has been highly beneficial both to policy development, but also program development. We now have a requirement that there's equity consideration in all of our budget requests through the city. We have an office of equity within the city that works with every department across the city to have equity action plans. We have equity considerations in all policy development in our policy review process. And we have a way of considering equity in most of all of our program development, whether it's through grant applications and other such things. So we're embedding equity in sort of every layer of the work that we're doing in a way that was not discussed, even 5 years ago. And I think that that evolution has even changed the way that we work with community in a way that's been really positive. And we still have a ways to go. I think it also sort of mirrors some of the measurement too, going back to kind of my comments about the policy. We're able to better measure how we're addressing equity, which I think has helped us identify the ways that we can actually do that program development and policy development and actually address the gaps and needs around equity within our city in a way that we never were able to before. And so I think, while we do have a ways to go, we're better equipped to do that kind of work.
I just wanted to add one other piece to these comments in terms of what we're seeing today, and just to be reminded that this didn't just start yesterday. And so as long as we pay attention to the fact that there's been a long history of racial bias and medical racism in the healthcare setting, that there's been a long history of how poorly shaped policies have disproportionately burdened communities, Black and brown folk in particular. As long as we acknowledge that, then we can pivot to at least being more intentional in how we empower communities, tapping into those assets and not treating them as deficits in community, making sure that there's an alignment of efforts so there's not the disconnect in all the systems. But at the end of the day, it's about having better ambassadors on the ground. So I say that because COVID is providing, while unprecedented, it's providing a unique point in time for us to reconcile some of this, not overnight, but over time. So I just wanted to underscore that this history that we're talking about, the lens that we use, you have to go further out to understand where we are today.
I love what I'm hearing about equity in all policies, community-led policies, and Claude, as you were saying, this is not a problem that happened overnight or all of a sudden. And in fact, we have policy, specifically misguided and discriminatory policies of the past, to thank for some of the disparities that we are seeing today, which is why it's so important that policy be a part of the solution. And of course, we also know that adopting policy is only half of the solution. So, when we look at the question of health equity, it's really core to City Health's mission and policies. And as Catherine and Katrina were talking about, we're going to be seeing a new policy of a new package of health equity policies that are more explicit about health equity. But I want to dig into this question about what happens after adoption. How can we help our equity goals really come to life by making sure that the policies are fairly and equitably enforced and implemented? Do you have strategies or ideas for what cities should be doing to ensure equitable outcomes when it comes to implementation? So what happens after we adopt these amazing policies?
I'd like to jump in if I can and just say, I started in public health as an evaluator. So the first time I saw the City Health presentation, it was all about this suite of policies. My first question was, how are you measuring that after a policy's passed? And, there wasn't this great answer, but I think it's coming, right? And it's still sort of left to cities to kind of figure that out. But that's what we should be doing. And I think, as we get more savvy and have these tools and have this ability to measure disparities in communities and how these policies might impact that, we should be projecting that up front. And we should be able to say, if we're modifying policies in certain ways before they're passed, we can say what those disparities might look like, depending on how we make those modifications. And that should be part of the planning in policy development. And so I think we're getting to a place where we're starting to be able to do that. And the more that we're able to do that, the more that we're able to educate, our policymakers, our leaders, and even our partners and stakeholders about how important that is in the actual policy development, so that we are passing policies that are truly addressing disparities. So that is critical in the policy development process as much as it is in the actual implementation and tracking going forward.
Just want to add 3 approaches to the question and then an example of what's happening here in San Antonio. So it's about leveraging these strategic partnerships in order to address the root causes of health disparities. So we really need to drill down. It's about making sure that we use continuous, consistent data collection and transparency with the public. Again, we want to make sure that we do a better job with that. But at the end of the day, it's about being more intentional with our engagement and our participatory approaches to policy analysis, development, implementation, and evaluation. So the entire arc. And I would just say that on the ground, again, I'm proud to be here leading the Metro Health Enterprise, but I will say that we have an Office of Health Equity that's been here for a few years. We have an equity action plan. We're working in collaboration with other city departments. The complement to that, which is going online as we speak, is an Office of Policy and Civic Engagement. Again, we're trying to be more intentional in how we do that to at least support the collaborations and the efforts on the ground so that we lean in a little bit more. So it does require taking advantage of some resources, grant funding opportunities, and the support by the city, but it's a complement to the Office of Health Equity. We now have this Office of Policy and Civic Engagement by design and not by default.
Adding to my colleagues, I'll say that again, that data is essential, and making the data available and in a way that the public and communities can use it for their own planning purposes is really important. And this is actually, I think, an excellent area for improvement across the public health system on how do we display data. As Tristan said, it's just essential to commit to doing it right in the beginning so that everybody knows and that you are going to do it. And then, as Claude said, to have it part of the larger strategy and make sure you are communicating it over and over and over again. But what I'll add is public health has not been funded well to do evaluation. And we need funders to make that commitment with us so that we can continue this work. Because we need to, as governmental entities, review policies and what is actually occurring with them. And I'll give 2 quick examples, but not always, elected officials don't always want their favorite policies evaluated and a light shining on them saying, it really didn't do what you thought it was going to do. So one of the ones that we're actively in King County looking at right now is our Board of Health has a helmet for bicycle helmets. Now, this isn't a city health evaluation, but in terms of safe streets, you can think about this. This has been a popular, and it's an injury prevention strategy. We know it works. And when an evaluation came forward, it turned out that the only enforcement that was happening, and in our county, it was through the police. Public health didn't have an enforcement capacity, ability or authority in this area. It was being enforced inequitably towards Black and Brown and the homeless. So once that came forward, then the Board of Health is needing to address that. And how does enforcement change? Because the policy in and of itself is a great policy. The other one I mentioned, which was from a number of years ago, is menu labeling. Menu labeling, caloric, that was a big public health push a number of years ago. When we looked at the outcome of that, who benefited from that, it was basically white women who were in middle and upper class, because it wasn't addressing the critical issues and the poverty issues and the food desert issues, the inaccessibility of food. So public health has to stand and say, I will change that. We will move forward together and change this, particularly when you open that box. The community has a lot to say, and you need to be ready for that and to make efforts to do better.
You know, I think this is a critical point that Patty made actually about willingness to evaluate those policies too. It's actually part of the policy development process to ingrain that evaluation and that shedding the light on what that policy actually is going to do and how we're going to evaluate it, because it's not always what people want to do. It's not necessarily what people want to shine the light on. And we have to be willing to put that forward and authentically look at the programs that we're developing, the policies we're developing, and the impact that they're having. And that's not always in favor. Let's put it that way.
Well, in this, if I may, just adding to the last couple of comments, two things. One, Tristan just reminded us of what we tend not to do. So applying the QI framework around PDSA, right? Plan, do, study, act. So we tend not to spend enough time on that study piece, or plan, do, check, act. Like, that's what have we learned here? What do we improve? So overlaying that as an approach to how we frame and shape policies, so we can at least do a better job understanding its impact in community. So that's one. The other, again, and Patty can attest to this, being one of many running these governmental public health departments, on average, when we survey health departments from coast to coast, we ask every 3 years through NACHO, National Association of County and City Health Officials, the profile. We ask, well, how many of you collect information? 9 out of 10 health departments say, yeah, we collect data. But when you ask the next question, well, what percentage of you have the actual bandwidth to do anything with that data? It's a fraction of that. And so the conundrum remains the same in an under-resourced discipline. So therefore, it requires strategic partnerships with academic institutions, with the United Ways of the world, with the nonprofit organizations, so we can do a better job not only analyzing the information, but making sure that we apply that lens to shaping better policies and by making use of that data. So just acknowledging a constraint of resources on the ground for health departments on average, but an opportunity to anchor, to enhance partnerships, to make use of that data.
Thank you all so much. I mean, I think it's really so clear that the question of unintended consequences and data and evaluation, so we have that continuous monitoring and that ability to understand are so critical. And maybe weaving together a couple of things, thinking about how in the last question, implementation is really where equity goals are either come to life or have terrible unintended consequences, Patty, in some of the manners you described. And the other place where equity goals either come to life or sometimes fall on its face is emergency situations, right? Just like we saw with the COVID ongoing pandemic, ongoing crisis, it has raged across the country, taken a disproportionate toll on the health and economic well-being of Black and Brown folks. And it has really posed a special challenge and hardship for our public health leaders. So, thinking back to whatever data you were able to collect, whatever evaluation you were kind of able to think through, what are some ways that if you were back in March 2020, I don't wish that on you, that was a very difficult time, what would you do differently? And honing in on policy, not just what would you do differently, but are there emergency policies that were put into place that you think should be made permanent? Might be in your city, might be somewhere else.
Well, I'll start with just a couple examples. I love this question. First of all, hindsight's always 2020. In March, of course, we were the first place in the country to have an outbreak in a long-term care setting. And what that did was really focus us in that and begin to develop policies that were actually used. CDC was out here with us and was used nationally for COVID response in that long-term care arena. But it really brought to light a lot of problems with the long-term care system, which often is not discussed within the healthcare public health sphere. It's often kind of on the side. We need to pay more attention to infection control policies within that and infection control capacity in public health. That's number one. The second one, which just delighted me, that I certainly hope we make this permanent, is that we moved the WIC program into virtual capacity, and women loved it. Our utilization of WIC services went up, the satisfaction with it went up, and therefore the connections to a healthier future. I really, really hope that we use this as a real example that these older programs, we must evaluate them, talk to our community. It has catalyzed us to relook at how our maternal child health services and work with communities is happening. And it has been powerful and really positive.
Just great question. Just would add, again, it's been a long year and a half around the globe. Applying lessons learned to your question, I would just say that what we realized more directly, more acutely is our fragility as a society. If we look at food insecurity, housing insecurity, job insecurity, I mean, imagine, if you will, that job type already being correlated with one's exposure to this bug, which loves company, by the way. So with that, we've learned, and we're still learning. So on the ground, we're looking at revisiting our paid sick leave policy. We've had that in play here in San Antonio for the last few years, but literally we've had some challenges on the ground, but it presents an opportunity to reframe, revisit, and represent the fact that this is a policy that we ought to have a robust one in place here in the city, but also revisiting as our health priorities over the next few years, the alignment of our food systems. Because again, COVID storm showed us the fragility we have on the ground that's impacting communities here across the city and the county. And so that's an opportunity to address what we've seen over the course of an acute episode, but which is going to have long-lasting impacts on the ground. So I'll just stop there just to acknowledge that conditions have been exacerbated, but we really want to seize on the opportunity to try to reconcile this into the future through better policies being in place.
And I'll just chime in quickly and say, no, it's not always policy is the solution. And oftentimes it's just more efficiency in the systems that we already have. I think Claude said it best. We looked at food insecurity. It more than tripled in Denver at the outset of the pandemic. And we were already working with a number of food pantries, but just organizing and convening with them regularly and then clarifying who could actually donate into the food rescue system and where they could donate. We actually rescued, I don't even know how many thousands of meals, but it was over 100,000 meals during the course of 2020 into the rescue system. And then, some other examples are just about, home visitations for clinical care was all but flipped on its head through our clinical partners. Some of the WIC improvements that Patty talked about, I think, are great examples. Some of the social safety net enrollments happening in a mobile fashion in whether it's WIC, SNAP, even childcare assistance. I mean, I think there's just a lot of different things that happened in social safety net programs that, were very simple system efficiency things that happened fairly quickly. That had we known, had we known and had we had our crystal ball, we could have done more easily and more quickly and been better prepared. But happened, and I think very easily could remain permanent and could be just the way things are now. So that's pretty exciting, actually.
I'd like to add one other thing here that these comments from my colleagues have brought to mind, and that's in learning with COVID, we know that ventilation is going to be a new frontier for the building and renovation, whether or not it's in schools, in restaurants, or in other businesses. And I think that we've learned so much about the problem with ventilation, and we have a golden opportunity for some policy advancement, which I hope will actually turn into regulations around the standards we have. As I was working with some of our sports teams up here in the Seattle area, I saw a willingness to test new things within arenas, and Climate Pledge Arena here that just opened with our new, I just have to say, the Kraken, our new NHL team, yay, to have an NHL team. They grabbed this and brought in expertise here with that building that was being built lifetime during the pandemic to build in new, innovative, advanced ventilation and air systems to test for the rest of the country, and to have a business partner do that might benefit everyone eventually is really great to seize on a policy opportunity like that.
Just wanted to add one other dimension to this, if I may. The episodic support in terms of funding has been somewhat disruptive for our workforce. So if you imagine the fatigue that's been, again, we're talking within the context of COVID, but these are issues that have been longstanding. So yet we do have to be more intentional with how we create a glide path. So career ladders and having more stable funding streams or diverse funding streams, or having access to supports like training or coursework, experiences and complements that augment the support for the workforce. So just a comment about, rather than doing this in reaction to, but to be more planful. And I know that this is at least referenced in the Public Health Forward blueprint that was released last week, that making sure that we do a better job in supporting the workforce. So I just wanted to add that as an additional commentary and context. Did we lose Aisha? All right. Oh, all right. So we can just keep chatting. It's been all fluid all the time. Oh, there we go.
Aisha, are you able to hear us? Well, in the absence of Aisha, this is Catherine. We're getting some really great questions in the chat box. I'm just going to read one out to you all. The adoption of upstream progressive health policy benefits from an organized, diverse community base of support. You all have talked a little bit about how you have engaged with community, and Patty, I love the fact that you don't even want to use the term engagement anymore, but it would be great if you could comment on the role of community support in the policy adoption being discussed here today.
Well, I'll start. And as I said, it's an opportunity for us to really develop new ways of lifting up community and having community really move things forward. So I think that one of the strategies that we used, as I mentioned beforehand, was we were actually using some of our funding that we got through grants or some of our core public health funding to pay local community-based organizations who were of the community to help develop and move things forward. Now, of course, we have to all recognize that as you do that, what the community decides they want to do sometimes is different than what the grant originally from the feds might have had as requirements. And so one of the things we need to look at is how do we build in that flexibility, because innovative strategies that come from these communities need to be honored. If they bring this up, we've got to find a way to manifest it. So that's number one. And secondly, we developed a pandemic community and anti-racism equity advisory committee that has been a table that has been amazing, including our faith-based organizations. And that needs to become a permanent structure in the King County area. It's been just golden. They help shape our mask policy, and in the very early days when we were debating on the use of masks, it was that group that had community-based organizations and others that shaped that policy so that the community really embraced it. And so the response became more a community response rather than government dealing with the pandemic. That was a defining moment that I really hope carries forward.
Patty, I so appreciate your comment again about empowerment, and I take it in the spirit and what kind of how you framed it, and how I heard it is that we tend not to be genuine in how we establish these connections in community. So It's the difference between speed dating and being in a long-term relationship, right? So we tend to approach community, hey, we've got a deal for you. And we've got to move away from that by design, which means asking the question on the front end. What is it that you would like to do, rather than imposing our will on community? And that's been the experience on the ground. And my lens has been shaped from Illinois to Maryland to Massachusetts, and newly landed here in Texas. So all that to say that I appreciate your comment. I would also add, it is about managing expectations across different networks, but it is about making sure that we anchor to our word and what our commitment is in community, in partnership, genuine partnership. So more to come. It's not just about describing engagement, which is plastic. It's really more about making sure that we make it real and we provide the resources to support community members on the ground who have a long lens and have a long lived experience outside of an acute episode like a global pandemic. So I appreciate your comment, and I agree 100%. We have an opportunity.
Yeah, and I'll just add one thing. I so appreciate the comments about compensating community members for their time and commitments to really power sharing in this development of what policy can look like in a long-term way. And it's not something that my office or even my agency led. It's something that came through City Council and through Budget Management Office. But for the first time in our budget process, there's actually a portion of the city budget, I think it's about $2 million, not real big, but it's something that is actually being seeded to a community-led process for guiding how that budget is going to be spent. And it's not just, what's your input and how this is spent, it's actually owned by community. And so, it's a start, right? But it's a long-term start, and that it'll be there every year, and hopefully it can expand from there. So, there is a commitment to long-term community-led budgeting. And I think that can serve as a bit of a model and where we might want to go with something like this, and is a long-term commitment to these principles. So.
Well, it's good to be back, and thanks for your patience while my internet flickered on and off. This truly is our new Zoom world. But as we look at a final reflection question for you all, I want to uplift something from the chat, which is, we've talked a lot about policies, but of course policies are just the tool, right? The goal is systems change, and systems change in the direction of equity and justice. So with that in mind, looking at the incredible challenges and unpredictability of the past year and a half, 2 years that, Claude, as you said, are symptomatic of things that have been in motion for generations and did not happen overnight. What are you looking ahead to see as some of the biggest health challenges facing your cities in the new year? And what are the solutions and innovations that you're looking to in the policy or broader systems change space that you think could help address these challenges?
I can start off. Just again, my lens has been shaped by this experience, not only back in Cambridge the last year and a half, but more recently the last 5 months here in San Antonio. So I will say that what COVID has taught us is it's literally reminded us of our fragility and the vulnerability of pockets of our community, this unevenness. So we are pivoting as we speak on the ground, trying to get through the holidays, trying to prepare for 2022. We don't want to jinx us in any form or fashion, but just acknowledging that this season we are expecting to pass. So with that, we have identified priority areas for the next 5 years that amplify perspectives and feedback that we've gleaned over the last few years. But so our work around mental health, our work around addressing food insecurity, our work around violence prevention, our work around access to care, our work around making sure we shore up our technology and infrastructure on the ground. But at the end of the day, making sure that we're more intentional in addressing health equity and social justice. So that is part of our rubric, as part of our 5-year plan. So nationally, we know last week the 5-year blueprint was released for public health forward. So on the ground, we're talking about SA forward, and that's really to align to our health priorities on the ground. So more to come, but that's what we're focused on, applying lessons learned from COVID.
I think Claude really nailed it with the topical focus as we move into next year. Mental and behavioral health is going to be a huge one, just with everything that we've experienced in the last couple of years. But at least not on a topical focus, but I think, from an underlying focus, just resiliency in general, and how we are better prepared for whatever comes our way. I mean, I think if COVID taught us something, it's that we weren't prepared. And I think Claude's using this term of fragility in our communities. We see where really our communities were not in a place to be able to withstand everything that came at us. And it was so variable in the way that communities were able to respond and be resilient. And so I think it's just how we understand that from a data perspective, and from a community-based organization perspective, and from a community member perspective, and where we are able to focus and build up that resiliency, so that whatever it is that happens next and whatever it is that comes our way, we are in a better position overall, and not in one community versus another. That's going to be a real focus for us moving forward.
Totally think Claude and Tristan nailed the different components here. What I'll kind of go a little more in depth to is from both the community and the workforce. I just want to talk a little bit about the mental health issues. I really believe that this pandemic is causing a level of trauma throughout our community that will be a generation. I'll use the example of a young mother that I talked to whose 3-year-old, when she took him outside, would cover his head with a blanket because his image of COVID was an evil thing outside the door that he was so afraid of. And she was seeking some guidance on how to help this child cope. And that showed a depth of issues within families, the trauma that children have gone through with the disruption in school and trying to do distant learning that doesn't work, particularly for a lot of our most vulnerable children. So this is a community crisis that is being amplified on top of a system in this country that is not ready to actually address the mental health issues that we currently had. And then let me move to the public health workforce. We have a lot of elected officials that are ready to move on. They're ready to move to this 5-year plan as Claude outlined so well. And we do not have a public health workforce that can transition with a snap of the finger and realign themselves and feel just happy to move forward. We have a critical problem. We're going to have a lot of staff burnout. They're going to be leaving. We're going to have vacancies. We're going to have to work together and with partners, with our elected officials, find the gracious space to rebuild, because our public health workforce is going to take some time and care along with the trauma that everybody else is feeling. So I think we have to work together to figure out what that means and how to address that, because we won't manifest these other things, and these policies that have been innovative are going to all fall apart if we don't pay attention to these core transition pieces that we need to do as leadership for our community, but for our workforce.
Thank you so much, Patty, Claude, Tristan. I speak for all of us when I say thank you for your wisdom and leadership. And I'm going to turn it over to Catherine to close us out.
I just want to reiterate Aisha's thanks. To all of our panelists, we so appreciate your time today, your energy, and also the work that you do on behalf of your city's residents. So thank you so much. Aisha, thank you in particular for leading such a wonderful, reflective panel today. We wish everybody a safe and healthy rest of the year. If you want to learn more about City Health, we welcome you to visit cityhealth.org and enjoy the rest of your day. Thank you so much. Bye-bye.